You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You're listening to ATS Breathe Easy podcast with me, your host, Dr. Eddie Qian, also the host of the ICU Ed and Toddcast. Each Tuesday, the ATS will welcome guests who will share the latest news in pulmonary critical care and sleep medicine. Whether you're a patient, patient advocate, or healthcare professional, the ATS Breathe Easy podcast is for you. Today, on the eve of World Pneumonia Awareness Day, joining me is Dr. Ramirez, who will discuss the diagnosis and management of community-acquired pneumonia. Welcome, Dr. Ramirez.
Thank you. Thank you for the invitation.
Absolutely, absolutely. So I think we should probably jump right into it. And I will say, you know, on the critical care side, one of the things I've been looking forward to is well, I guess maybe not looking forward to, but watching out for is the Surviving Sepsis Campaign Guidelines. And, you know, this document I'm preparing for like 200, 300 pages. But one of the things that first strikes me about this update to the guidelines I recently put out is it's more focused. Why did we decide to do an update before we kind of jump into all the things that y'all focused on?
Yes, I think that yes, you just essentially bring the point that if we want to be comprehensive in any topic of medicine, in a couple of years that you from the prior guidelines, there's so much new information. And it's so much nuance that we'll have to, we want to make a guidelines for the full management of community-acquired pneumonia. We are going to end it with 200 pages. But more important than this, we are going to take probably 4 years to go through all the evidence. Then, and then we all recognize that if we spend 3 years, 4 years for a publication, it's already useless, the way that we move in medicine. Then the ATS now decided that in the new guidelines for pneumonia, the first thing that the committee did was, okay, what are 3 or 4 questions that, based on our experience, has moved to the point that we need to have some update? They're still having a comprehensive update of every management of community-acquired pneumonia. We say, well, site of care, where the patient should be managed, in the hospital, ambulatory, what patients should be in the intensive care unit. Well, we have not evolved too much from the prior. Then why reviewing things that we are going to come out probably with the same recommendations? Then essentially, moving forward, this is going to be focused updates. This is why in this guideline, there's only 4 questions that we address. And the goal is, okay, instead of waiting another 5 years, probably 1 or 2 years, another 3 or 4 questions. Then you keep moving with more frequent guidelines, with whatever we consider is the area, in this case of community-acquired pneumonia, with more evolution based on the evidence that we have.
Yeah, so that makes a lot of sense. I think that makes a lot of sense. And so based off of what I'm hearing, we should be expecting more of these smaller updates, at least for the community-acquired pneumonia guidelines. At what frequency do you guys anticipate having these kind of updates out? And it's okay if you don't know that now.
Yeah, no, I don't know that now. I know that the goal is to have every 2-3 years to have an update and, okay, what happened in the last 2-3 years in what area? Another thing that was interesting, for instance, is that one of the questions that we have this time, that was the role of ultrasound in the diagnosis of community-acquired pneumonia. In the last guidelines, there was not even a discussion, because this is an area of medicine that has evolved so quickly. Now, ultrasound, I mean, you being in critical care, I mean, this is part of your everyday life. Then there's so much, because remember in the past, they were just very specialized, and the instrument had moved so quickly, it's so portable. Now this is part of training, not initially were the pulmonary fellows, but now it's even training of the medical students. Then sure. All of a sudden, and the way that medicine is moving, is going to be very interesting to see what is new in the last 2-3 years, and just to move very quickly with these updates.
Yeah, I'm a big fan of ultrasound, as you already pointed out, as a critical care provider. You know, there's discussions about, should we replace the stethoscope with an ultrasound? You know, I'm not quite there yet, but yeah, it really has moved really quickly. But yeah, I guess that's a good segue into that first recommendation which is looking at lung ultrasound versus a chest X-ray to diagnose community-acquired pneumonia, where the guideline, where this update says, for adults with suspected community-acquired pneumonia, we suggest lung ultrasound is an acceptable alternative for chest X-ray in medical centers where appropriate clinical expertise exists. So this is interesting. So you mentioned, we didn't have this question even discussed in the last iteration of guidelines. What changed? What happened that made you and the committee think that we need to make a comment on this?
Well, as I partially alluded, a technology that evolved very quickly, a technology that is available, and also the recognition that these guidelines, even though they are the ATS IDSA guidelines focus on in the US practice, but the recognition that we will go globally because these guidelines are used globally, and in significant number of places, having an X-ray, a chest X-ray machine is not even there. Then the ultrasound, then we say, well, the ultrasound may resolve a lot of issues when we have in the diagnosis of pneumonia. We all recognize that I mean, the problem with pneumonia is a syndrome. No, we don't have a test to say, okay, you have pneumonia, you don't have pneumonia. The patient has signs and symptoms. We listen to the chest, but again, the stethoscope listen to the chest. Then we always say, well, the only way to more or less know if the patient has the alveolar inflammation, the local inflammatory response. We need to have a chest X-ray to see the white blood cells in the lung. Then you have the pulmonary infiltrate. Okay, I have the alveolar inflammation. But if the chest X-ray is not there, then it may be a lot of overuse or underuse of antibiotics because of poor diagnosis. Now the ultrasound may resolve this problem in areas where chest X-ray is not too available. But the challenge that we have is that we look at the literature, and the literature is there, but it was not all these recommendations have been. We suggest because we couldn't find an article saying, okay, these patients were managed with ultrasound, these were managed with chest X-ray. What happened with the outcomes? It really is the ultrasound is as good as the studies were. There is an ultrasound, there is a chest X-ray, and now I'm going to get a CT scan because there's something, and then compare with CT scan. Then there were not too many. We couldn't find an article looking at clinical outcomes in patient managed with ultrasound. But I think that was enough for us to say that if the chest X-ray is not available, or you are in an ER and you have the ultrasound and the ultrasound is positive, don't wait for the chest X-ray. The patient fulfilled the criteria. You define a local inflammatory response. This is community-acquired pneumonia. Go ahead and manage the patient as community-acquired pneumonia.
Yeah, no, I think this is also very pertinent because I want to come back to one of the points you made that, there are places where the chest X-ray isn't readily available, but if you have an ultrasound machine, you can always go ahead and do it. That's why we call it point of care. Even in my own practice, and I've done all my practice here in the United States, that sometimes it takes a while. We have the chest X-ray machine, but for various reasons, sometimes the portable chest X-ray can take a while, depending on how busy the emergency department is or the hospital is. What I really appreciated about the guidelines was that if you dive a little bit deeper into the text, you also give us what kind of things we should be looking for. And so these are things that I'm teaching medical students and residents about when I'm looking about lung ultrasound, be it consolidations or irregular contours, air bronchograms, air trapping, B lines, the presence of pleural effusion. So personally, I really do appreciate how the guidelines really were a little bit more specific other than just lung ultrasound as a general term. The next several questions, they're kind of split into different recommendations between whether you're inpatient or outpatient, and whether you have severe versus non-severe pneumonia. Inpatient versus outpatient, I think a lot of people already understand. But how do you want clinicians to determine severe versus not severe as we talk through the next several questions?
Yeah, this is a very important factor. I may say that for clinicians now that seems to be in the medical literature, we tend to characterize patients in different groups. And in the case of community-acquired pneumonia, where we say, well, there is mild, moderate, and severe. The problem is very simple to say, oh, this mild, moderate. The question is, what is the definition?
Yeah.
Then, but we tend to agree that a mild community-acquired pneumonia, outpatient management, moderate, admitted to the hospital to the ward, severe, admitted to the hospital to the ICU. Then you can say that the location, the site of care, more or less can define if you are mild, moderate, severe. Then, as a general rule, we may say that, well, if the patient has community-acquired pneumonia and you are evaluating the patient and is sick enough to be in the ICU, this patient qualifies as severe community-acquired pneumonia. Again, site of care based on severity. But in reality, for this consideration, the severe community-acquired pneumonia, we mentioned in this guideline, we apply the same criteria that the prior guidelines use for the ATS IDSA criteria for severe community-acquired pneumonia. Then there is the major criteria that will be you have respiratory failure to the point that you, let me put it this way, from the host response. See, we are discussing with clinicians from the host response. We know that the diagnosis is based, there is a local inflammatory response, there is a systemic inflammatory response. Okay, local inflammatory response, cough, which has chest red, positive ultrasound, systemic fever, leukocytosis, this VQ mismatch, there is hypoxemia. This is all what happened there. Now, we know that if the patient is going to have severe pneumonia, is going to move into a dysregulated inflammatory response or a hyper-inflammatory response. Now, the question is, how do we recognize this dysregulated inflammatory response? And it's going to go into organ dysfunction or organ failure. If we go all the way to organ failure, our life is simple. You already have respiratory failure. You need to be on a ventilator. Well, this is severe pneumonia. Or you have hypotension. It doesn't respond to IV fluid. You need vasopressors. Well, this pneumonia, you have septic shock. Then in these two, you need a mechanical ventilation, need a vasopressors, respiratory failure, septic shock, you have severe pneumonia. The question is how to identify the patient with organ dysfunction that still doesn't have failure. And in this regard, we still consider that the minor criteria that were described by the ATS, IDSA before, then for the clinician, it's almost like another way to look at this is, okay, the patient doesn't have respiratory failure that doesn't need mechanical ventilation, but the PAFI is getting worse. The oxygenation is getting worse. Then this moving to severe pneumonia. Doesn't need vasopressor, but I need to get fluids to maintain blood pressure. It's hypotension, move to severe pneumonia. From the CNS, the patient is confused, is moving into severe pneumonia, confusion. For hematological failure, the patient has thrombocytopenia, or is moving into severe pneumonia. From the hematological failure, if the patient has increased lactic acid, is moving into severe pneumonia. From a renal failure, if the creatinine start moving up, the patient is moving into severe pneumonia. Then it's all these quote-unquote minor criteria where you have 2 or 3 of these, this patient we can define is having severe pneumonia. Then I may say that it's a matter of the clinician looking at the patient and understanding the pathophysiology. Is this patient having a dysregulated inflammatory response? Is this patient is moving into organ failure? And then you define severe community-acquired pneumonia.
Yeah, no, it makes sense. And it's helpful for me as a critical care provider and doing a lot of research that a lot of these overlap with the SOFA criteria, the sequential organ failure assessment, which we use in the sepsis 3 definition to determine sepsis. And so there's a lot of overlap seemingly.
No, so, I agree. If you were to be doing SOFA scores, again, this is not part of the community-acquired pneumonia, but still, to me, it's a very good way to be looking at, okay, how is that the organs are moving? Then the deterioration of the SOFA score will be also considered the patient moving into severe community-acquired pneumonia, yes.
Yeah, absolutely.
Clinicians, want to feel more confident caring for patients with serious illness? The American Thoracic Society and the Center to Advance Palliative Care have teamed up to bring you a brand new 7-course CME series on ATS Ed+. You'll learn practical, real-world skills in palliative care basics, symptom management, and communication for tough conversations. all designed to help you make a difference at the bedside. And the best part? You'll earn CME credit as you learn. Find the full series on atsedplus.thoracic.org.
So the next question from the guidelines is talking about antibacterial therapy for patients who also test positive for a respiratory virus, which I think, to summarize, and please correct me if I'm wrong, if you have an adult outpatient without comorbidities that you think has community-acquired pneumonia and they test positive for a respiratory virus, that the committee suggests not prescribing empiric antibiotics. But if you are an inpatient or you have an outpatient with comorbidities, then you suggest prescribing empiric antibiotics. Is that
Yes,
correct?
yes.
And how did you guys land on that?
Exactly. Because this is a little also different from the prior guidelines. Because with COVID-19, with the pandemic, PCR for virus became more standard. Then, and nowadays, we start recognizing more and more patients with community-acquired pneumonia. They have a positive PCR for SARS-CoV-2, for influenza, for RSV, and with these panels that we tend to do multiple viruses. Then the question is what to do with this patient with RSV positive PCR. That the patient has RSV pneumonia, or he has RSV pneumonia plus pneumococcal pneumonia. Is this just a viral pneumonia, or is it a viral bacterial co-infection? That has been always the issue with influenza. Is this just influenza, or is influenza plus Staph aureus plus? And then the question is when the risk for viral bacterial co-infection is low enough that you're going to say, I feel confident not to give antibiotics. And the only place that we feel confident not to give antibiotics is that you have pneumonia. I'm going to send you home because you're going to be treated at home and you don't have any comorbidity. You are almost a healthy person, and I have influenza, RSV, even rhinovirus. Well, this probably is just a viral pneumonia. I don't need to give you antibiotics. This is a big difference from the last guidelines. That in the last guidelines we say, well, whenever we have a virus, since we never know who may have a bacteria, we give antibiotics to everybody. Now we have a group that if this person is healthy, no comorbidities, you have an influenza, and of course you get an X-ray, you have a big alveolar infiltrate, you're still going to give antibiotics. This is why there is a table in the guidelines, table 1, that will say what favor these recommendations or not. Then you have a 40-year-old, no COPD, no diabetes, he's healthy. Yes, he has an influenza, and you get an X-ray, and there is a big alveolar infiltrate. Well, this is influenza plus pneumococcal. And we're not going to say, send this patient home without antibiotics. You have to look at the patient. But if you have, the classical SARS-CoV-2, you get an X-ray, a little bit of ground-glass opacity, the patient is fine, the white blood cell count, you get white blood cell count is 11,000. Don't give antibiotics. This patient has just a viral pneumonia. Now, once you get admitted to the hospital, you have comorbidities, we still say that we decided to give antibiotics and then do the workup. And in 24, 48 hours, blood cultures are negative, procalcitonin is normal. And then you start coming with putting the case together to see, is this a viral pneumonia only or a viral plus a bacterial pneumonia? You may discontinue antibiotics or not. But empirically, we think that we don't have enough laboratory or clinical data in a hospitalized patient that can tell me, oh, this is a viral pneumonia, and I'm not concerned that he may have a bacterial co-infection.
Yeah, no, I think this is really interesting to me. In fact, if I take a step back away from community-acquired pneumonia or otherwise, it seems like historically there's been this push for antibiotics and early antibiotics in particular. But as we do this more and more, there's pushes both on the, well, maybe not everybody needs antibiotics. And antibiotics are medicines and drugs just like anything else, and everything has their side effects. And so if they're not a benefit, then they're just represent risk without a benefit. But then the other side of it, which is actually the third guideline question, it's an unintentional segue, is can we shorten that duration of antibiotics? Do we need that longer duration of antibiotics? I remember through my training and through all the board exams and test taking, we have to memorize, oh, for this infection, we need this length of antibiotics, and for this infection, we need this length, and it's 5 days, 7 days, 10 days, 14 days, 6 weeks for some things, 8 weeks for some things, and it's just a whole big soup. But we're challenging that now.
No, exactly. I think that we challenge this for the logical reason, and this is why in these guidelines there's been a lot of emphasis of phenotyping the patient with the idea that we need to tailor therapy. And of course, in retrospect, now we say that how could it be that for pneumococcal pneumonia, you cannot have a fixed number of days for any infection, because it's going to depend on the pathogen, the virulence, the bacterial load, the immune system of the patient, how the immune system is going to respond, are we given the appropriate antibiotics. Then duration of therapy needs to be individualized. The question here was, what will be in a patient that is responding very well, that you hit the right antibiotics, that the patient is not critically ill, what will be the minimal duration of therapy? And here is that when we say, okay, how short can we go? This is different from the prior guideline. The prior guideline, we said, well, a minimum of 5 days, because probably if we give less than 5 days, some patients are going to relapse or we're going to have recurrent pneumonia. But now there are not too many studies, just a handful of studies, indicated that the patient is not sick. Of course, we are not discussing severe community-acquired pneumonia, but the patient has pneumonia and doesn't have too much of a comorbidities, and it has a very good clinical response. Probably 3 days of antibiotics is sufficient for patients that we don't have any evidence. And again, and here we separate some pathogens. Staphylococcus aureus may take longer. Pseudomonas is going to take longer. Then there are some pathogens that definitely are going to take longer. But Streptococcus pneumonia, Haemophilus influenza, Moraxella catarrhalis, the patient is doing fine, very rapid clinical improvement. Probably 3 days is all that you need. Now, the question is, how many days do we need to sterilize the alveolar of a patient? But of course, we don't know. But another concept there is that you are relatively healthy. Probably in 3 days, I decrease the bacterial load in your lung to either you don't have any more Haemophilus influenza, or whatever is there, your macrophages are going to take care of this. Then we're not saying that in 3 days, everybody is going to have an sterile lung, but probably in 3 days, we flip things around, and if the patient has rapid clinical improvement, 3 days is going to be all what is necessary for a significant number of patients. Now, at no point we say patient with pneumonia, use 3 days. No, we need to look at the patient and say the patient is stable, doesn't have any complication. Of course, there's no pleural effusion, there's not lung abscess, because you can get better, but if there's no bacteremia, everything looks good, then 3 days is all that you need.
Yeah, no, that makes sense. And especially since there is a disclaimer early in the guidelines to say that these guidelines weren't meant for those who are immune compromised. Exactly. That if you get to this point, you're talking about like there's sterilization of the alveoli, but you don't need that, right? So you can get to the point where our immune systems can take back over, as you said. So that makes a lot of sense to me. And I think when I talk with patients about this too, it's, you don't need to take antibiotics until you feel back to 100%, right? And I think that's an important part of an expectation setting. After 3 days, you probably, hopefully, will be feeling a little bit better, but you might not be feeling all the way better, and that's okay. As far as the natural progression of this disease.
Agree.
In this antibiotic duration section, I think two of these recommendations or suggestions are pretty straightforward. For adult outpatients with a community-acquired pneumonia who reach clinical stability, we would suggest less than 5 days, at least 3 days of duration. And then for adult inpatients with severe community-acquired pneumonia, we suggest 5 or more days of antibiotics. But this middle one, at least just by pure percentages, seem to have the most, I don't know, controversy might be a strong word, but the most disagreement within the committee, where for adult inpatients with non-severe community-acquired pneumonia who reach clinical stability, we suggest less than 5 days of antibiotics, minimum of 3 days duration, rather than 5 or more days of antibiotics. And said 69% of committee members voted in favor of this, section. Can you are you privy to taking me behind?
Yeah. But this was yes, a critical issue because here there is some data suggesting that 3 days may be enough in studies with a lot of exclusion criteria, and there was and they're looking at mortality, and there was one patient in the short course therapy that died because the patient has Staph aureus bacteremia and received 3 days. And as we discussed, Staph aureus bacteremia for 3 days. Then the question here is, the patient is hospitalized. Well, I don't want to bring my bias into
No, this is your time to shine.
well, no, but because I was part of the negative vote here.
Good. That's perfect. That's exact.
The patient is hospitalized. The patient is hospitalized. We have 5-6% mortality, and the difference between 3 days and 5 days is not such, to me, not such a big deal in this patient. Then I would say the problem is that this is for a very, very selected group of patients, and I'm concerned that with so much, if we just say hospitalized patient can be treated with 3 days, someone may miss that this is Staph aureus, or this is, or the patient has pleural fluid, and because I've seen so many patients with community-acquired pneumonia, when we review our empyema cases at our VA hospital, a lot were patients with community-acquired pneumonia treated with short duration of therapy, but essentially we miss that there was a collection of fluid there that required more. I mean, and I wanted to be a little more conservative in the hospitalized patients. But the majority, but this is why it's interesting that you pick up on this 69%. This was a very controversial recommendation. Okay, yeah. to give 3 days for the person that was sick enough to be hospitalized. Because this is another thing. Oh, the patient is hospitalized, but who is hospitalized? If you are very liberal, everybody gets hospitalized. But at least in the United States, now, to be hospitalized, you have to be sick. You're not going to get into a hospital with a moderate pneumonia. Then I was considering that probably it's better to maintain the 5 days for the hospitalized patient. But it was a big discussion.
Yeah, no, it's good. I think it's guidelines can be considered so black and white.
No, this is you pick up on this. This is why we decided that it was very important to put the percentage of people that vote one way or the other, because then, because otherwise the guidelines recommend this, and then you are there and say, well, I tend to disagree, but then you can figure out, okay, what was the agreement? When you have, because there were 9 ATS members and 9 IDSM members, then you will say, well, this 100% agreement. Then you can say, well, most likely, again, we don't have a good evidence, but at least these 18 people are doing the same with the evidence that we have. But when you have a disagreement among the committee members after 1 year of discussion, you may say, well, I can follow this recommendation or not, because there's not agreement among the quote unquote experts.
Yeah, I personally, as a clinician, I really appreciate it, because I think it is important to highlight these gray areas where it's not as black and white. Some of these are pretty easy, but if it was easy, that's not what I need the guidelines for, right? I need the advice and the expert recommendations for these gray areas. And so I've really appreciated that. And I think a lot of people do too. But the last question, I think, was a little bit more clear, talking about like 100% agreement with some of the committee members, and it's talking about corticosteroids for community-acquired pneumonia. And this recommendation was pretty straightforward and had a lot of agreement. For inpatients with non-severe community-acquired pneumonia, we recommend not administering systemic corticosteroids. And then for adult inpatients with severe community-acquired pneumonia, we suggest systemic corticosteroids, and there was near 100% on both of these for agreement. Why was this something that you thought the committee needed to comment on? And take me a little bit behind the scenes on some of this.
Yes. Well, again, this was in the prior guidelines. The recommendation was not to give steroids because, but then since the last guidelines, there have been a couple of very good prospective studies. Still, one very good prospective study done at our VA hospitals here across the US that was negative. Steroids didn't decrease mortality. One very good study done in intensive care units in France that showed that steroids decrease mortality. Then it doesn't mean that the new evidence is all very clear, but there was a discussion looking at the designs of the studies and what happened, and then of course looking at other studies, and meta-analysis. And there was a consideration that even adding the negative studies were more in favor of steroids decreasing mortality. The question still is in severe community-acquired pneumonia. Then when we separate non-severe and severe, in non-severe community-acquired pneumonia, there is no decreased mortality. Then probably non-severe, we can gain the toxicity or the adverse events without any clinical benefit. The non-severe was simple. But in the severe, then there were some studies positive, some negative, but in the meta-analysis, I think that was you need to treat 18 patients or 17 patients to get one decrease mortality. And at this moment, we thought that until more evidence is generated, probably if we need to make a decision now. And people say, well, based on this, what would you do in your institution? Well, I think that we recommend steroids for severe community-acquired pneumonia. The retrospective data on influenza, community-acquired pneumonia, again, this is not prospective randomized, but retrospective data has been that steroids may even deteriorate outcomes. Then the studies, for instance, the French study decided to exclude patients with influenza. This is why we say that in influenza, probably we don't recommend steroids because retrospective data, but who knows, when we get prospective studies, we need to figure out. But then for influenza, for aspergillus, we don't recommend steroids, but for the classical bacterial pneumonia, severe community-acquired pneumonia, probably steroids. The challenge is that we all recognize is the patient has the quote-unquote cytokine storm or the hyperinflammation, probably steroids may be good, but the problem is that it's difficult to identify these patients. And we go back to Eddie, your first question, what is severe community-acquired pneumonia? Because right. We still don't know. Then if I were to know for sure that this patient has severe community-acquired pneumonia due to hyperinflammation and due to a cytokine storm, well, probably steroids are going to be good. But then there are so many other reasons where the patient may deteriorate clinically. And the patient may have hypoxemia. This is an acute MI that developed because of the pneumonia. And the hypoxemia has nothing to do with cytokine storm. It's because of congenital failure. Then we're still trying to, this is why we discussed that looking at the clinical phenotype, we say, well, the patient needs to have severe pneumonia, some form of organ dysfunction. Looking at the inflammatory phenotype, ideally we want to see very high elevated CRP. That is telling me that now I have a little bit of organ dysfunction, but I also have, even though the CRP, that is a reflection, as we know, of the level of interleukin-6 that goes to the liver and favor production of CRP. Well, if I have elevated CRP, but now that we are going to be able to measure more cytokines, but we still have to define the patient that is hyperinflammation that will benefit the most from steroids. And this is part of what we mentioned, future research, better biomarkers to define the patient that will benefit better from steroids.
Yeah, no, you already pointed it out, and it is a little bit full circle for this conversation for me too. You know, I'm a intensivist, so I can keep things a little bit simple for myself to make it easy. But if I think that the problem is inflammation, then the anti-inflammatory medicine like steroids seems like a reasonable choice here. So when you get into, you were talking earlier in this conversation about severe community-acquired pneumonia, you're talking about this dysregulated systemic host response to inflammation, and maybe that's where the problem is. That this makes a lot of sense. But yes, of course, you know, I'm very active in some of the research talking about, like, you know, uh, different patients who present the same might have different etiologies, whether it's a inflammatory phenotype or whatever. So there's a lot of what you say about future research that resonates with me personally here. I think, you know, so that those were the 4 questions that we talked about for the guidelines. In addition to the recommendations that were made, is there anything that you would want to share with clinicians as it pertains to the treatment of community-acquired pneumonia?
Well, I may say that one of the challenges that we have is that as we learn more, it's interesting. In pneumonia, I may say that I've been doing research in pneumonia for years. We always say there's a balance between the pathogen virulence and the immune response, not immune protection. And in the past, we give a lot of emphasis to the pathogen and the right antibiotic, but now we are learning more and more that probably the host response is critical. And as you alluded, this type of the modulating the host response, we are going to be having more and more ways to modulate the host response. Then steroids is another thing. Steroids is a big thing that downplay the full immune system. That probably this is a very broad spectrum. We need to be a little more specific, and we learn to modulate the host response. And this goes back to that's happened all across medicine. If we want to do personalized medicine, we need to do better phenotyping, and we need to do also, I mean, phenotyping for the clinician. That will be, the pneumonia is not a simple group of patients. We can subclassify the patients, and this is important now. I see a patient with pneumonia. Is this severe pneumonia, not severe pneumonia? Is this inflammation, no inflammation? These are characteristics that I need to classify the patient. But now in research, we know that the endotyping of patients, trying to define at the molecular level what is the pathogenesis of that is happening. Then we have considerations like proteomics, metabolomics, transcriptomics, and then we see these very nice articles that show the patient is admitted with pneumonia, and now I have all these 100 genes, and these genes are elevated. These are all inflammatory genes. And then I say, wow, I can figure out at the genetic level. And then I want to know the patient has a bacterial pneumonia, a viral pneumonia. This is inflammation. Well, this is in the future, but I don't know. I don't know how far in the future. Now with artificial intelligence, I don't know, in the future, maybe tomorrow. But again, we are moving from phenotyping to endotyping, and this can be a totally different way. That then we can definitely do personalized medicine in community-acquired pneumonia.
Yeah, no, that makes a lot of sense. That makes a lot of sense for me overall. And I'll point out that you mentioned artificial intelligence, not me. I think that's come up on every single episode that I've recorded here with the Breathe Easy. Is there anything else that you want to talk about today, Dr. Ramirez?
No, I think that we covered. We did a big overview.
Great. Well, thank you so much for your time, and thank you to everyone listening for joining us for today's ATS Breathe Easy episode. Please subscribe and share this episode with your colleagues. Put it on your calendar to register for the ATS International Conference in Orlando in May. Early registration opens January 2026. Members get a discount on conference registration, so become a member or renew your membership to take advantage of the savings, and we will see you next time.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.